Welcome back here on OncoDaily. Very honored to have Dr. John Gore and Dr. Petros Grivas. I know that one of the practice-changing studies at AUA was the CISTO study. And I really like the fact that it started from the patient's journey. And so I want to pass it off to Petros, if you could introduce yourself, and then also Dr. John Gore. And so we'll let Dr. Petros Grivas do the moderating.
Thank you so much, Chandler. Wonderful to see you and John. What a great opportunity here. And very quickly, I will introduce myself. I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle at the University of Washington and Fred Hutchinson Cancer Center. I'm a professor and serving as the clinical director of the GU Medical Oncology program. I'm very honored and excited to work with Dr. John Gore, learning from him and working with him side by side. It's exciting. Of course, to discuss, John, I will let you introduce yourself, and then I will ask you some great questions.
Thank you both, and great to see you both. Petros, as you know, I have to go on a webinar, a podcast, or go to a meeting to see you, even though we work at the same institution. My name is John Gore. I'm a urologist and professor at UW and the Fred Hutchinson Cancer Center. And my main practice is helping patients with bladder cancer. And I oversee a research program, and CISTO is part of that, that tries to apply health services and patient-centered outcomes research to the problems that patients with bladder cancer face.
Thank you, John. And you have done amazing work over the years leading the field. Let me ask you, just to set the stage for our audience today, there has been so much activity and improvement in the options that we have, especially in the setting of BCG-unresponsive, non-muscle-invasive bladder cancer, with recent FDA approvals, as well as retrospective data with intravesical chemotherapy. Can you give us a little bit of a high-level overview of those options, and how does this fit, into the question about optimization of therapy and patient-centered approach?
Yeah, I think the key word that you mentioned is options. So when I was a younger man with no beard and all black hair, we really had limited options for what to do when BCG failed our patients. And that's something you'll learn from the leadership at BCAN. Patients don't fail their treatments fail our patients. But when BCG failed to effectively treat the cancer, our hands were effectively tied. And the options really were clinical trials and then removal of the bladder. And now what we have are truly a litany of options. There are sort of the by-the-book options where you can, in theory, go back to the well and give more BCG, but a lot of people worry, reasonably so, that if BCG didn't work, more BCG is unlikely to. But there are fairly effective chemotherapy options, and what we have started to do is, rather than give people a single chemotherapy into the bladder, we do these combination chemotherapies, the most common of which is gemcitabine and docetaxel. And there's really, as you mentioned, Petros, really high quality retrospective and even some prospective data now indicating that it's a pretty effective treatment in terms of durable disease-free survival 12 and 24 months after people have a recurrence. But where we've really had some increase in the available options has been through work of some of our industry partners. Really, the first one was Keytruda. So Keytruda was approved as a therapy for recurrent CIS, BCG-unresponsive CIS, but didn't gain tremendous traction in the community. I think some of the real-world data showed that some of the DFS data was not that much better than reinduction BCG or even chemotherapy with valrubicin. And so what you saw the field really shift toward this combination chemotherapy strategy. But in the last 12 to 18 months, we've seen two additional therapies get approved. One is Adstiladrin, and the other is notopedenkin. So those are, that's also called Anktiva. Those are newer therapies that have different mechanisms of action. The Anktiva needs to work in conjunction with BCG, but now we're talking about much more impressive disease-free survival and response data. And so we're able to offer patients therapies where we're not just kind of throwing darts at a wall. These therapies have some efficacy data that's pretty impressive. And before I presented the CISTO data at the AUA, we also saw some reports on using cretostimogene, which is another viral vector-based therapy in BCG-unresponsive disease, using the Pretzel, TAR-200, and BCG-unresponsive disease. So even though we've seen a lot more options in the last 2 to 5 years, what we also know is that option list is going to go up in the next even just 12 months.
It's really impressive, John, what is happening in this disease space. And thank you for crystallizing for us, the recent developments, FDA-approved agents, intravesical chemotherapy data. And I know a lot is going on with intravesical therapy with the TAR-200 program, the corticosteroid that you mentioned. I think the future is bright and creates more options, to use the keyword here. And obviously, as you pointed out before, one of the options, even more before we had those options that we talked about today, was and still is radical cystectomy. And that's a main, I would say, dialogue with the patient about pros and cons that you guys are doing. In the context of all this, there is an option of intravenous pembrolizumab based on the Keynote 057 trial data, single-arm study. Having said that, I think the uptake of intravenous pembrolizumab, I would probably argue, is relatively small in real practice, and mainly because of the development of all the intravesical therapy options you mentioned, John, and of course, the patient selection that some patients may need radical cystectomy. So how do you navigate through that number of options, and how did this question and dialogue help you design the CISTO study?
Yeah. So I think, to wade through it, I think it's what is unique about these recurrences in bladder cancer is there's no great sort of algorithm for how we make the best decision we can make. Maybe one day we'll have some biomarker or genomic test that really allows us to do targeted therapies for non-muscle invasive bladder cancer, but we're really not there yet. So a lot of it right now is still, throwing stuff at the wall and seeing what sticks. The way that our medical system works, cost is an important consideration. It's an important consideration for our health system when we're figuring out what medications we're going to approve stocking at our institution. But it's also a consideration for our patients who may have a copay per dose that could be really burdensome for them. So we are forced to consider cost as we navigate these. Fortunately, the combination chemotherapy that we all use with gemcitabine and docetaxel is fairly inexpensive. The main cost there, to be honest, is the cost in terms of expensive clinic utilization and clinic resources, because it's just more to give 2 therapies. And I think, the other thing that we do consider is we have this sort of potential of window of cure, because this is still non-muscle invasive bladder cancer, we think, and we don't want to lose that window. And so this is where we circle back to this idea of radical cystectomy. And cystectomy was used much more commonly in the 90s and early 2000s for recurrent high-grade non-muscle invasive bladder cancer. And with these newer therapies available, I think we're seeing it used less and less. And this is where our CISTO study really highlighted that as we navigate these newer therapies, taking out the bladder, more definitively treating the cancer, it actually should still have a role, in our algorithms of care for these patients.
Absolutely. And I think that's a main take-home message, I think, from your presentation. And I think, in this wonderful opportunity of more options for the patients, as you pointed out, John, trying to individualize approaches is key. And we're not there yet in terms of molecular biomarkers. But you're right, we're using clinical criteria to help patients, navigate through that menu of options and, of course, choose what is best for them, what makes them more comfortable. So let me ask you, take us through this amazing journey of the CISTO study. I remember when you started working on that a few years ago, and you created like a community. You created a network of people, navigation, patient advocates, of course, other urologists, advanced practice providers, nurses. That's a huge network that you created. So take us through that journey in a summary so the audience can understand what happened and what the main results of the CISTO study have been.
So one of the most important, meetings that I had was meeting Angie Smith, who is a professor of urology at University of North Carolina, who is my partner in crime in this whole kind of journey. And long ago, now over 10 years ago, we created the bladder cancer in partnership with Petros, are amazing collaborators at BCAN with the Bladder Cancer Advocacy Network, the Patient Survey Network. And that allowed us to understand what questions are important to patients. And their top 2 questions for non-muscle invasive bladder cancer are, how do I make a decision and what is the best timing for when I should consider a cystectomy. And number 2 was, what do I do when BCG doesn't work? And those are our top questions too. Those are the things that we struggle with. How do we know when to start twisting a patient's arm to consider cystectomy? And, what's the next step in salvage management? And so we distributed those to funders, and PCORI took it up as a priority topic. And sometimes the best grant mechanisms are the ones that are written for you. And so what we did was, rather than sort of overlay on an existing network, we created essentially like an ad hoc cooperative group with our friends, really, with partners from the working group that we were in BCAN, but also kind of colleagues and friends in bladder cancer care across the country. And so CISTO recruited patients from 36 sites across the U.S., inclusive of 7 community sites. Because if you think broadly about where bladder cancer is treated, most bladder cancer is not treated at the Fred Hutch. Most bladder cancer is treated at community centers and with community urologists. And so it was important for us to capture that real world experience. And we were able to enroll 570 patients, including almost 200 radical cystectomy patients. And, you mentioned kind of the multi-stakeholder input that went into it. One of the big things that input led to was us figuring out what outcomes we were going to primarily measure in CISTO. And so the primary endpoint is different than what you get in an industry-sponsored trial, which is almost always either clinical complete response or 12-month disease-free survival. Our primary endpoint was 12-month physical functioning, so a quality of life endpoint. We have all those clinical endpoints as secondary endpoints, but the main thing was to sort of ask this patient-centered question: if I undergo a cystectomy for my recurrent non-muscle invasive bladder cancer, what's my physical health and well-being going to be like in a year? Am I going to be in good health with good quality of life, or would I have been way better off if I kept my bladder?
And this is a very important patient-centered approach, John. I think I had heard you say before in many meetings that the most important questions are the questions that patients are caring about and asking about. And this is a great example of that. So having that as a primary point, being generated from a patient survey through the colleagues at the Bladder Cancer Advocacy Network, I think makes CISTO a very unique study in that regard, and makes it a pragmatic study, of course, that was able to get funding, through the PCORI mechanism and try to answer this important question. So you saw the data very elegantly at AUA, and I know the manuscript is also a major milestone. So you mentioned that the key endpoints was a 12-month physical function. Any other key take-home messages from the presentation for the audience to take home?
Our hypothesis going into CISTO, because radical cystectomy, removal of the bladder, is such a big operation, big recovery. Our hypothesis was that they would have worse physical functioning at this early endpoint, but it was actually the same. It was non-inferior. So you could tell a patient, if we take your bladder out in 12 months, you're going to be doing just as well physically and with your overall quality of life as you would if you had kept your bladder. But some really important secondary outcomes were actually surprisingly better after cystectomy. So they had better emotional well-being, less anxiety, less depressive symptoms, and better financial well-being with lower financial toxicity. There were some things that were worse. So if you look at their bowel function and their sexual function, they were worse. And that's partly because when you take out the bladder, you take out the prostate as well. And you can do nerve-sparing surgery, but its effectiveness is not as good as leaving those nerves undisturbed. And we use the bowel for the urinary diversion. And so you can see that the bowel function outcomes were almost as good around 12 months, but not quite there.
Very useful data. And I think to your point, John, this reinforces the idea that there are multiple parameters that patients should keep in mind when they make those decisions. And I think these data are very helpful in that decision making. So how do you plan to apply these findings in the clinic, tomorrow? How do you use the data to help patients make an informed and shared, good, comfortable decision for them?
So our team has a lot of experience with figuring out how to create tools to either be patient-facing tools so they can understand more about their quality of life outcomes or how to interpret some of their health information documents. But we've also learned that, you can create this cool, fancy schmancy tool, but if it's external to the electronic health record, it's just not going to get used. So what we're trying to do as we think about how to disseminate and implement the CISTO results is we're trying to figure out how to create facile, almost like checklists that allow you to sort of profile the patient in front of you and say, well, gosh, this is a patient that definitely does better with bladder-sparing therapy. And we should think about some of these secondary intravesical options that might be a good match for this patient. Whereas this patient with a different profile clearly did better in the CISTO study with bladder removal surgery, and we should more strongly talk to them about it and even give them sort of like an executive summary of the data. So that's kind of what we're trying to do right now. We have some really cool data on health state utilities and preferences for all of our patients. And so we're trying to create, a couple profiles. If you're a patient with bladder cancer, can CISTO be a room of similar patients that you walk into and say, gosh, who here is like me and how did they do? And what's the balance of risks and benefits of these two treatment options that I'm trying to consider? So that's a big next step. The other thing is, you're a cancer provider. I'm a cancer provider. We all know that 12-month outcomes are important, but longer-term outcomes are important as well. And so we have funding from NCI to get longer-term outcomes, both clinical and patient-reported on all of our CISTO patients. So that's going to be 2-year and 5-year outcomes on everybody in CISTO. But then it's also going to allow us to continue recruiting a CISTO 2 cohort. And the CISTO 2 cohort is going to be patients who have similar inclusion criteria as CISTO 1, but in this kind of newer contemporary era where, they're going to be trying to decide between some of these more expensive therapies. And our main endpoint for that is not physical functioning, it's financial well-being.
Super helpful, John. And I'm very, very happy to hear that the CISTO2 is going forward. And I know how much work is going to get into that. It's so important for the patients. And the aspect of financial toxicity is so important that we start to recognize it even more and more as we get more therapies and, of course, more expensive therapies. And these sometimes intangible, hard to measure out-of-pocket costs the patients may have, including things that you're working on, transportation, parking, lodging, things, that are hard to sometimes think about, but are relevant to patient care. So I think it's super useful to have this data set as you work on. A last question, maybe before we go, John, you mentioned the amazing role and partnership with the Bladder Cancer Advocacy Network. I'll take this opportunity here, Chandler, to advertise we're having our annual bladder cancer walk. John and me have been doing that with Jonathan Wright and Sarah Sutka and other colleague members for many years. We're very excited for this event. The Bladder Cancer Advocacy Network new CEO is here in Seattle now, and she's going to join our walk. And it's such a great partnership to have that collaboration with them. So the last question for John is, since BCAN is about patients and caregivers, I know you're working so much with all these aspects. Can you comment briefly about the role of caregivers and how you try with your research to inform data regarding those?
Yeah. So this is where we're lucky about the subsequent NCI funding, because in our first round of CISTO, we did have a whole aim dedicated to caregiver quality of life. And this idea that, number one is having a caregiver an important adjunct to helping you have better outcomes. And number two, what is the burden on caregivers, when they're helping someone through a complex cancer diagnosis? And those aren't easy questions to answer. And I think we've done a poor job just in oncology and healthcare in general, caring for our caregivers. We unfortunately had to cut that from CISTO 1 in our budget kind of reconciliation, but we are assessing caregiver quality of life outcomes in the CISTO 2 cohort. So we will be able to look in parallel with our patient outcomes at caregiver burden and caregiver quality of life. And that's going to help us think not only about, how this decision impacts my general quality of life, my financial well-being, and my emotional well-being, but also the burden on my loved ones. And so it's going to be, I think, really exciting to be able to parse that out.
Wonderful, John. This is so meaningful work, and thank you for all you're doing for our patients. I know we serve many patients together, and of course, overall in the field, your collaboration with BCAN, with Dr. Smith, and many others is really commendable. So I take the opportunity to thank you for the contributions. Thanks for your time today, and looking forward to more discussions, my friend, as we go forward.
Anytime, and thank you guys for highlighting the CISTO study. Very excited to talk about it.
Wow. I tell you, I love that discussion. Petros, John, a practice-changing study at AUA and patient-centered. And I like the fact that, by doing this study, radical cystectomy remains an important treatment option. And also at 12 months, the different groups that you guys looked at in terms of, like the emotional well-being, quality of life, financial well-being, urinary sexual bowel health, and so you really covered a lot of the things that our patients find very important. So thank you so much, John. Thank you so much, Petros. And we'll go ahead and put the link down here for that study directly. And when you get that paper, let us know. We're excited to read it.
That was great. Thank you so much.
Thank you so much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.